This video demonstrates the technique of intraosseous needle insertion using the near needle holder. An intraosseous needle can be inserted within minutes for emergency vascular access for children in shock when intravenous attempts have failed. It can be used for fluid resuscitation and medication administration in children less than 6 years of age. The needle penetrates the skin and bone cortex and enters the medullary cavity bone marrow. The only contraindications to IO insertion are fracture near the access site or local cellulitis. Here are the steps for inserting the intraosseous needle. Stabilize the leg. Put on sterile gloves and clean the skin over the upper tibia with alcohol or bethadine. Use a sterile drape. The near needle holder was developed to insert a standard hollow bore needle into the tibia. Attach the sterilized needle holder to the hub of the needle. Identify the site for insertion. Go 1 finger breadth below the tibial tuberosity and 1 finger breadth medially on the flat area of the tibia distal to the growth plate. Inject local anesthetic to the skin and periosteum if the child is conscious. Measure the depth so that the tip of the needle will enter the medulla. Grasp the insertion device so your middle finger lies at this point. Insert the needle through the skin at a 15-degree angle towards the foot to avoid the growth plate. Apply firm downward pressure and rotate the needle until there is a loss of resistance as the needle goes through the cortex of the bone and into the marrow cavity. Grasp the lower hub of the needle with the hemostat and twist off the holder. Flush 2 mL of saline through the needle to dislodge any bone debris. Confirm the proper location of the needle prior to starting a fluid infusion. A properly sited needle should stand on its own without support if it is through the bone cortex. You can usually also aspirate bone marrow. Then infuse a 10 ml bolus. There should be little resistance and no extravasation of fluid into the soft tissues. If you make a hole in the cortex, do not put another hole in the cortex of the same bone, as this will result in possible fluid extravasation into the soft tissues. Give a 20 ml per kilogram bolus of saline via a syringe. Stabilize the needle with gauze pads and tape. The IO needle should be replaced with a conventional IV line within 24 hours to minimize the risk of complications. Complications of IO insertion. Extravasation of fluid into subcutaneous tissues is the most common complication. It may result in compartment syndrome and muscle necrosis. The risk of osteomyelitis in children is less than 1%. Fracture at the IO insertion site and fat embolism are other rare complications. Radionucleotide studies have demonstrated that fluids can be infused just as quickly through an intraosseous infusion as by the intravenous method. Intraosseous fluids may be life-saving in children who are in shock. All emergency medical responders should know how to use this technique.